Okay, good morning. Let's go ahead and get started. My name is Alan Schroeder. I'm the chair of the Grand Rounds Committee here at the Department of Pediatrics. I'm feeling a bit starstruck today, given our guests, Admiral Rachel Levine. So excited. And I'm going to let Dr. Neville Golden introduce Admiral Levine in a short period. But and thank you, Neville, for helping to procure this esteemed guest. Before we get into that, though, let's go over some housekeeping. The text code is on your left. That will also be placed into the chat. That is your way to get CME for today's talk. And then if we can go on to the next slide. Please join us next Friday for the annual Chief Resident Grand Rounds. This is always one of my favorite parts of the year. The chiefs do such an amazing job of putting together their scholarly work for the year and presenting it always in a very eloquent fashion. So this will be a great talk. This has been an amazing group of chief residents. Please join that. Next slide. And then save the date for, we're fast forwarding to October, but this is worth putting on your calendar because really some great speakers, leaders in our national health organizations that will be talking about the important topic of community engaged research at our 5th annual MCHRI Research Institute Symposium. Please put your questions in the Q&A so everyone can see them. And Dr. Golden, take it away.
Thank you very much, Alan. It is my distinct honor and privilege today to introduce our guest speaker. Admiral Rachel Levine serves as the 17th Assistant Secretary for Health for the United States Department of Health and Human Services, where she fights every single day to improve the health and well-being of all Americans. She is working to help our nation overcome the COVID-19 pandemic and build a stronger foundation for a healthier future, one in which every American can attain his, her, or their full health potential. Dr. Levine's storied career, first as a physician in academic medicine, then Pennsylvania's Physician General, and then as Pennsylvania's Secretary for Health, has focused on the intersection between mental and physical health, and often treating children, adolescents, and young adults. She is a pediatrician and an adolescent medicine specialist who founded the Division of Adolescent Medicine and the Eating Disorders Program at Penn State Hershey before becoming Pennsylvania's Physician General. I am proud to call her a colleague and a friend of many years. And in fact, at dinner last night, we worked out that it's actually in excess of 30 years. In recognition of Pride Month, her topic today is challenges and opportunities facing pediatric populations with a focus on LGBTQI youth, perspectives from the Assistant Secretary for Health. Thank you. Rachel?
Well, thank you so much, Neville. I am just so pleased to be here. Thank you for inviting me, and it's really an honor to call you a friend and colleague for over 30 years. So I suspect every one of you will remember the day that you took, or if your students will take, the Hippocratic Oath to do no harm. I took that oath in 1983, and I was called to medicine, as many of you were, by my desire to help people and work towards the common good. Our medical education gives us extremely important skills, but what makes us truly physicians, nurses, and other medical professionals is our choice to spend our days and often our nights helping our fellow human beings live well. As we know, medicine's about treating illness and saving lives, but also improving the quality of life. We are there for emergencies and pandemics. We're there whenever people need us. We try to make sure that the sick get better and we help healthy people stay healthy. We make sure that those who need professional medical help get that help, no matter who they are or what their life circumstances might be. Our oath is thousands of years old. It tells us to treat patients without discrimination. I have truly loved being a physician since the day I took that oath. I have believed in it, all of it, for as long as I can remember. We all work every day to benefit the sick, to protect people from harm, and to make our community whole. We can do that with medicine. We can also do that with warmth, empathy, compassion, and understanding. Well, right now, our communities need healing. Our nation needs healing, now more than ever. Today, many young people living in this country need our attention because they are being attacked and too often they see few places to turn. Lesbian, gay, bisexual, transgender, and queer Americans and youth are attempting suicide at an alarming rate. According to the Centers for Disease Control and Prevention, Adolescent Behaviors and Experiences Survey, which covered January to June of 2021, it was published actually April 1st of this year, 1 in 4 teenagers who identify as LGBTQ+ reported attempting suicide during the first half of 2021. That's not suicidal ideation. They attempted suicide. 1 in 4, 25%. Just as alarming, 46% of teenagers who said that they were LGBT seriously considered a suicide attempt during that time. So they had suicidal ideation, almost 50%. The CDC found that compared to cisgender heterosexual students, LGBTQ+ respondents reported higher percentages of poor mental health during the pandemic, persistent feelings of sadness or hopelessness, and fewer close connections with their peers at school. A September 2020 brief in our Journal of Adolescent Health titled, "I'm kind of stuck at home with unsupportive parents right now. LGBTQ youth's experiences with COVID-19 and the importance of online support," was published after youth around the country, of course, had been social distancing for some time. This paper found that LGBTQ youth were facing considerable additional stressors while staying at home and studying remotely, in addition to those faced by their peers. The youth remarked that they were concerned about conducting therapy sessions over the phone while at home, while fear of being overheard by their parents. They were unable to express themselves or live fully in their identities, and they felt trapped at home. The authors noted that given the potential for long-term physical distancing, concerted efforts are required to provide necessary resources and support for LGBTQ youth during the pandemic, unquote. The data we have about suicide attempts and suicidal ideation among this population suggests that not enough resources and not enough support have been brought to bear. The Trevors Project 2022 National Survey on LGBTQ youth mental health, based on responses from over 34,000 LGBTQ youth, found that 56% reported their mental health as poor, most of the time or always due to the pandemic. A report drawing on the same data administered before the pandemic, found that youth would at least, this is 2019, that youth with at least one accepting adult, however, one accepting adult were 40% less likely to report a suicide attempt. So it takes one supportive adult to reduce the risk of youth LGBTQI+ suicidal ideation and attempted suicide. So, the Department of Health and Human Services has made improving and supporting Americans' mental health a top priority, particularly our youth. Our Surgeon General, Vice Admiral Vivek Murthy, has spoken often of the need for better and more effective mental health supports, and he published an advisory last year titled "Protecting Youth Mental Health." He noted in the advisory, our healthcare system today is not set up to optimally support the mental health and well-being of children and youth. A couple of the recommended steps for healthcare organizations and health professionals: implementing trauma-informed care principles and other prevention strategies to improve care for all youth, especially those with a history of adversity; referring patients to non-medical resources such as economic supports, school supports, and legal supports; screening children and adolescents for mental health challenges and risk factors; implementing school-hospital partnerships, such as behavioral health urgent care clinics supported by schools, looking at new payment and delivery models, and building multidisciplinary teams. So we need to take these considerations very, very seriously with a real sense of urgency. After decades of social progress, the most vulnerable among us continue to suffer. LGBTQI+ individuals of color, LGBTQI+ youth, which we've been discussing, but also seniors and immigrants, transgender women of color and transgender youth of color who live at the intersection of multiple systems of oppression. That intersectionality are more likely than the population at large to suffer not just harassment, but violence and murder. And so with all the progress we've made, these challenges are day-to-day reality for many of our youth. The transgender population faces particularly significant health disparities. The latest survey to date by the National Center for Transgender Equality in 2015 found that respondents faced high levels of mistreatment and violence, economic hardship, housing insecurity, stigma, and discrimination, with significant impacts on physical and mental health. As highlighted in a 2020 report from the National Academy of Sciences, Engineering, and Medicine, Transgender and non-binary people face increased risk of sexually transmitted infections such as HIV, chronic conditions, and particularly psychiatric comorbidities such as depression and anxiety when compared to the general population. Now, these negative health and life outcomes are being misrepresented for political purposes. They are frequently described as the inevitable result of mental illness, and they are described as unpreventable struggles faced by quote unquote unfortunate people, rather than the lack of compassion and sometimes the denial of professional care. Numerous articles, many published in 2020, often in the Journal of Adolescent Health has a number of articles, have noted that there is nothing inherent with being transgender or LGBTQI+ that predisposes youth to negative mental health outcomes. Nothing inherent in being on the rainbow that predisposes these outcomes. It is the bullying, harassment, discrimination that transgender youth face which leads to these mental health conditions. Study after study show that transgender youth that are supported by their parents, school, and community receive evidence-based care, have actually excellent mental health outcomes. Now, one challenging article that has been frequently quoted was by Dr. Lisa Lippman of Brown University in August 2018. And this was entitled Parents' Reports of Adolescents and Young Adults Perceived to Show Signs of Rapid Onset of Gender Dysphoria. It warned of trans epidemic and contagion of the transgender self. Now, this report was based largely on how parents reported rather anecdotal experiences, more of a qualitative study with their transgender children. It was based on parents' reports, not kids' reports, and it's been widely criticized for its bias and its methodological flaws. In fact, the medical evidence we do have suggests that there is no widespread social contagion creating the phenomenon of transgender self-identification. So a paper in June 2019 in Translational Andrology and Neurology titled Demographic and Temporal Trends in Transgender Identities and Gender-Confirming Surgery did highlight the fact that there are more people living in the country than identify as transgender or gender non-binary. But the medical literature attributes this to better survey methods, asking better SOGI information, greater social acceptance and visibility, not societal changes and quote unquote contagion. The data shows that trans and non-binary kids begin to identify when they're relatively young, and the vast majority by age 20. As authors of the 2019 paper note, these findings are consistent across respondent age groups, which suggests that reports of growing trans and non-binary prevalence are really attributed to increased awareness, acceptance, and self-reporting of trans and non-binary young people, rather than an actual increase in prevalence. Now, it's very important to note that the fact that the appropriateness of a range of medical treatments, evaluations, and treatments of people who are transgender and transgender youth is thoroughly grounded in medical research. And we do not lead state laws and actions that dictate principles of transgender medical care by us, pediatric experts, many at our nation's outstanding children's hospital, including Stanford Children's Hospital. Studies clearly show that gender-affirming care results in positive mental health outcomes. And I won't quote them all, but there are 6 articles published in 2020, 4 articles in 2021, and 1 new one in 2022. Now, there is a broad consensus about transgender medical care and gender affirmation treatment and its appropriateness. The American Medical Association in 2021 states that medical and surgical treatments for gender dysphoria, according to DSM-5, are medically necessary as outlined by generally accepted standards of medical and surgical practice. Our own American Academy of Pediatrics, in a policy statement in 2018, advocates for gender affirmative model of care. The American Academy of Child and Adolescent Psychiatry, in their policy statement, outlines affirmative clinical practices. The Endocrine Society in 2020 states medical interventions for transgender youth and adults are effective, safe, relatively safe, and established standard of care. Of course, more research is necessary. The Pediatric Endocrine Society in 2017 states transgender youth have optimal outcomes when affirmed in their gender identity through support by their families and their environment and appropriate mental health and medical care. Our own Society for Adolescent Health and Medicine in 2019 said that these health services are medically necessary services for youth, and gender affirming care is medically necessary, safe, and effective. There is no room for the politicalization of medical care for our youth. But unfortunately, many states are taking actions which politicize the medical care of transgender and gender diverse youth. Now, it's not uniform, and even in states that have had legislatures that have passed that, governors in Indiana, North Dakota, and Utah have spoken out about them and actually vetoed them. However, many of these vetoes have actually been overridden by their state legislatures. Governor Spencer Cox of Utah published a statement vetoing their House bill, which blocks transgender youth from playing sports with other students of their gender, pointing out that of the approximately 75,000 students participating in Utah in high school sports, the law applied to 4 of them. Quote unquote, rarely has so much fear and anger been directed at so few. I do not understand what they're going through or why they feel the way they do, but I want them to live, unquote. His veto was overridden by his state legislature. Now, the best estimate drawn from the CDC's 2017, so it's a little dated, Youth Risk Behavior Survey is that about 1.8% of US youth identify as transgender or gender non-binary. The Trevor Project found that many children and adolescents who identify as LGBTQI+ actually avoided athletic participation due to actual or feared discrimination. And I don't think it's just feared discrimination at this point, given the many state actions and laws that have been proposed and passed. This is consistent with the Center for American Progress's 2021 report, Fair Play, the Importance of Sports Participation for Transgender Youth, that states that only about 42% of trans youth participate in sports. And that means that it is clearly a distinct minority of youth participating in sports are transgender or gender non-binary youth. A lot of it has really hit the news, precipitating many of these laws and actions, because at the University of Pennsylvania, one young transgender woman won some races and won one national race. Doctors know how to help patients. We know how to treat these patients. There is no reason for states to get in the way of our doctor-patient relationship. And there are very good reasons that we leave medical decisions to medical experts like us, rather than relying on political actions. So we as medical professionals need to feel an extra measure in care and caution for the welfare of children, adolescents, and adults who are transgender and gender non-binary. Because we know that with these societal pressures, they have worsened health outcomes related to the population at large. Now, Healthy People 2030, which is actually created through my office at the Assistant Secretary for Health, includes several important national public health goals specific to this community. And it's worth naming them to get a sense of how acute and pervasive these health risks are. The objectives include, for Healthy People 2030, increase the number of national surveys that collect data on transgender populations. And we are working to do that, collecting more and more SOGI data. There was a recent National Academy of Science, Engineering, and Medicine report on the state of the art of collecting SOGI data that is published. And that's exactly what we're going to be doing in the federal government. Increase the number of states, territories, and the District of Columbia that use the standard module for SOGI in the Behavioral Risk Factor Surveillance System, the BRFSS. Reduce bullying of transgender students. Reduce the proportion of transgender high school students who use illicit drugs, and reduce suicidal thoughts in transgender students. The Healthy People 2030 objectives are not political. In this, they resemble the standards of care for the treatment of transgender and gender nonconforming people developed by WPATH, the World Professional Association of Transgender Health, and its US arm, USPATH. Both are based on expert input and extensive documentation. So in pursuing Healthy People 2030 goals, we are doing no more than following peer guidance and best practices. The Department of Health and Human Services helps in this regard by providing evidence-based resources available for free online at health.gov/healthypeople on everything from suicide prevention to helping people support LGBTQ children. So please take advantage of these resources. Now, the effect of the COVID-19 pandemic has presented specific additional health challenges to youth, as we've been discussing. Societal changes wrought by COVID-19 go beyond the health effects. And a lay publication for Slate, there was a quote. Last year, a student in Minneapolis was outed when school administrators contacted their parents, using the plural pronoun, after a surveillance software system flagged LGBT keywords in their writing and the school's ability to screen students' writings is becoming more and more invasive. This was in Minnesota. The COVID-19 pandemic has brought about a significant shift in the use of surveillance software by schools. Simultaneously, a growing reactionary backlash against school policies affirming and supporting LGBTQ students is resulting in legislation, lawsuits, and pressure campaigns to implement anti-LGBTQ policies, such as been implemented in many states, including particularly some of the most egregious in Florida. These are turning schools into a surveillance apparatus uniquely suited to outing and marginalizing at-risk LGBTQ students. So to respond to this, we pediatricians, adolescent medicine specialists, other pediatricians, and other medical professionals that care for children at our outstanding children's hospitals, including, of course, Stanford, need to speak about our compassion, our provision of evidence-based care, and our support for LGBTQI+ students, particularly transgender and non-binary students. I firmly believe that as a society, we have not made progress unless we have all made progress. Acts of intolerance damage our nation's health and well-being, including our nation's mental health. If anyone that believes that words are not the same as actions, that believe that LGBTQI+ people should toughen up, please walk a mile in our shoes. Now, personally, I have no room in my heart for hatred, and I have no time, frankly, for intolerance, but not everyone in our country feels that way. We all need to advocate and to work against intolerance until everyone can live in America in their lives openly and freely without fear of prejudice, scorn, and attack. I feel that our lessons of our recent history is that our mission of doctors, in addition to our usual academic missions, which I know very well after many years in academic medicine, including our patient care of children and families, including our education of students, residents, and other physicians and other medical professionals, our research, clinical and bench research, and our administrative actions. We need to add to that, another mission, which is advocacy, to be proactive rather than just passive, and to proactively reject this intolerance. We have the ability to share information, to speak with authority that our training and our experience has given us, to work together to assert our right to practice medicine as we were taught to do. We were taught to help patients without discrimination. That was back to the oath. We were taught that we do not deny patients care. Our ability to follow our basic tenets and precepts is being questioned and in some states erased. President Biden and our administration see the LGBTQI+ community in all of its diversity. We have a president and a vice president and a secretary who support equality and work to ensure that everyone is represented. That gives people a voice, an ability to affect change, and the opportunity to help people and understand the diverse needs of our nation, including, of course, our health needs. So at HHS, Secretary Becerra and I and our entire department are absolutely committed to doing everything that we can to help all vulnerable patients and their families get the medical care that they need, no matter where they live, no matter their life circumstances, no matter who they love, and no matter who they are. Medical and political discrimination, medical discrimination against LGBTQI+ people has to end. We are not there yet. As I've been saying, many politicians and their supporters are describing our LGBTQI+ community in public as a blight upon our culture. Many of the targets of this kind of speech, many of our youth are driven to try to kill themselves. We know as a fact that trans youth are being harassed in public and driven to the depths of despair at an alarming rate. We know that 50% of transgender and gender non-binary young people seriously contemplate suicide. So I want to point out that for LGBTQI+ children, adolescents, and teenagers that may be having a mental health crisis. And the difference, through the Trevor Project, the difference between life and death is one single caring adult. It doesn't have to be a parent or a family member. It might be a teacher. It might be a coach. It might be a religious leader. It might be their doctor or their nurse. It makes all of the difference in the world to hear one supportive person reminding that you are a valuable human being, that your life is important, and you have no less dignity than anyone else. No one should feel so low that they need to hear those words, but they do. They need to hear those words every single day, all over this country. Having a supportive person to bring them through these difficult times has saved the lives of more LGBTQI plus youth than we will ever know. One supportive adult. You know, trans people are doctors and lawyers and teachers. They run businesses. It says here in my notes, they drive taxis, but I think it's probably more Ubers and Lyfts. They're even the Assistant Secretary for Health. Unfortunately, I do not see enough warmth, empathy, compassion, and understanding on their behalf in our country. I certainly have not seen it from those who target them for isolation, bullying, rejection, anti-trans actions, and legislation. Our children are watching us. They're watching what we do. They're watching how we act. So we need to publicly say to every LGBTQI plus person living in this country, to all of the youth living in this country, that it is okay to be you, and it is the right thing to stand up for your dignity and your freedom. Gender-affirming care is medical care. Gender-affirming care is mental health care. Gender-affirming care is suicide prevention care. The data is very clear that it supports and improves quality of life and it saves lives. It is based upon decades of study. It is well-established medical practice. The World Professional Association for Transgender Health published evidence-based guidelines in 2011, and there will be a new update this summer. There'll be a new update of WPATH this summer. WPATH analyzes the full state of the science. I've seen the drafts. It provides substantial, rigorously analyzed, peer-reviewed recommendations to the medical community on how best to care for patients, including our youth who are transgender or gender not binary. There is nothing one-sided about their approach. There's nothing political about their approach. It is founded on a vast body of medical literature. This is the way that medicine is supposed to be practiced. This is the way we care for patients with standards, evidence-based standards of care with regular updates. Updates coming this summer. I also refer people to the Endocrine Society's clinical practice guideline published in September 2017 in the Journal of Clinical Endocrinology and Metabolism, entitled Endocrine Treatment of Gender Dysphoric, Gender Incongruent Persons. This is available online, and I've talked with them, and after WPATH updates their standards this summer, they will work to update their standard of care. So that's about 5 years. For almost 40 years, I've considered it an honor to be a doctor. I firmly believe in our role as healers. I believe in our role as truth tellers. The truth we need to confront now is that medicine and science are being politically perverted around the country in ways that can destroy people's lives. We've reached a tipping point for the role of medicine in civic life and the health of well-being of LGBTQI plus Americans in general, and particularly youth. A paper published in February of this year in JAMA Network, Open Network, entitled Mental Health Outcomes in Transgender and Non-Binary Youth Receiving Gender-Affirming Care, found that receipt of gender-affirming care, including pubertal blockers and gender-affirming hormones, was associated with 60% lower odds of moderate to severe depression and 73% lower odds of suicidality over a 12-month period. That was published in February 2022. Those who now attack our LGBTQI plus community are driven by an agenda that has nothing to do with medicine. It has nothing to do with science, and it certainly has nothing to do with warmth, empathy, compassion, or understanding. They're rejecting the value of supportive medicine, rejecting well-established science and basic human compassion. They prefer slander, bigotry, and gender-baiting hate speech. We as doctors and people who love our community and who love our nation have to confront the fact that the language of care and compassion that we take for granted being used by physicians is being used to tear our communities and our states and our nation apart. It is being used to drive patients to suicide. We have to stand up. It is our duty. It is part of our mission to stand up and take a stand on those who need us, on the youth, on the young people who need us. We have to be doctors and nurses and other medical professionals. We have to do that even when it's hard and even when it's difficult. One supportive adult. Thank you so much, and I'm pleased to answer your questions.
Wow, that was amazing. That powerful presentation really will make each of us think and continue to do the work that many of us are already doing. There are a couple of questions, and Admiral Levine's presentation is open for discussion. The first one, thank you so much for your advocacy for LGBTQ youth and being with us today. Our virtual PrEP program for youth at Stanford provides free confidential access to HIV prevention and medication in California. And we also support other states in setting up their own HIV prevention programs for youth. There is tremendous variability in state-by-state access to confidential reproductive health care. What do you see as potential for federal support for confidential free care instead of relying on states?
Well, I think that we are certainly, in terms of telehealth, going to try to confirm in regulation many of the advances that we had during the COVID-19 pandemic that continue because of the public health emergency. So I can't tell you when the public health emergency will end. We're still in the midst of COVID, but we're going to try to embed those changes in terms of telehealth. I think that as we do that, there will be opportunities for funding through HHS and grants to support evidence-based telehealth services and working to make sure that there are telehealth services across states. You know, not only is gender-affirming treatment for youth and adults at risk right now, but of course, with the pending Supreme Court decision, you know, reproductive health care for women is at risk throughout our country. You know, I've been through all around the country now and have been to some, refuge states such as California and such as New Mexico and Colorado, where I think you're going to see many women looking for reproductive health services and many transgender and gender non-binary youth and adults trying to access care in California. And I think you're going to see quite a wave of that. So we need to work with you on ways that you all are going to be able to cope with those numbers. I heard a term a couple of days ago from some stakeholders, LGBTQ stakeholders in San Francisco, called gender refugees. And what they're talking about is not people who are leaving other countries coming to the United States. They're talking about refugees within the United States. They're talking about people who are going to move from Texas and Arizona and Oklahoma and Idaho and other states to Colorado and New Mexico and right here in California and perhaps Washington and Oregon as a refuge to the type of actions that I've been discussing. So I think you're going to see an influx. And of course, the federal government will do everything we can to support you. So I would expect some grants that support those excellent activities.
Thank you. There's another question. Could the legislative prohibition of accepted medical gender-affirming care be construed as the practice of medicine without a license?
I don't know if it can be construed as that, but so the way we're trying to impact this at HHS is through three pillars. One is advocacy, which is what I'm doing right now. And the secretary has spoken, the president has spoken, the vice president. So we're going to continue to advocate throughout the country, including a speech I gave about a month ago right in Texas, in Fort Worth at Texas Christian University, and speeches I'll be giving in Florida for Pride at the end of the month. In addition, we need to work on policy. And so the policy change, and this is where I think we can have action, is through the Office of Civil Rights' interpretation of Section 1557 of the Affordable Care Act. This states that you cannot discriminate on the basis of sex. And it is our interpretation that that includes sexual orientation and gender identity. After those rules are promulgated, that will inform all the divisions of HHS, including CMS, in terms of insurance coverage. And then people, actually, you can even do that now. People who feel that they are suffering discrimination because of these actions can file a case with our Office of Civil Rights and they will investigate. Also, Title IX is being interpreted that way by the Department of Education in terms of students in school. The final is legal, and the Justice Department is filing briefs. They filed a brief in Alabama where their law was stayed. The law in Alabama said that doctors who perform gender-affirming care, meaning your gender-affirming clinic, would be guilty of a felony for performing that medical care, that evidence-based medical care at their children's hospital. That would be a felony. So that law was put on hold by the courts, and our Justice Department was active in that. So we're going to work on advocacy, policy, and through the legal avenues.
Okay, here's another question. Please discuss your opinions about the root causes of LGBTQI plus baiting and discrimination. Is there a connection with denial of women's rights to control their personal reproductive health?
I think that there is a connection. I think that one of the connections is political. I mean, I think that the recent increase in anti-LGBTQI plus laws, specifically these laws and actions that are targeting vulnerable transgender youth, gender non-binary youth, and their families, is politically based. One of the political operatives for one of the governors clearly stated that. He said, this is a winning issue for us, and we're going to carry this all the way to the election. And so I think that the recent increase, I mean, there's nothing new about the care we've been doing. We've been, you know, we've been providing this care again at, you know, Penn State Children's Hospital of Philadelphia, Pittsburgh Children's Hospital, DC Children's Hospital, Nationwide Children's Hospital, Stanford Children's Hospital, UCLA Children's Hospital, et cetera, for many years now. I think that that this is politically based. The other, though, I think that for many people in our country, especially in rural areas, but other areas too, people fear what they don't understand. And I think for many people, these issues, particularly of gender identity, are beyond their experience, or at least they think it's beyond their experience. And I think it's very true that people fear what they don't understand. And so I think that's why education by expert medical professionals such as yourselves, by pediatricians and our colleagues throughout the nation can play a pivotal role about the medical nature of the evaluation and treatment that we're providing, by the standards of care. And that, as I mentioned, you know, transgender people are, you know, we just live our lives and try to work for the common good like anybody else. And I think that we get pillared and vilified now for purposes. So I think education has a very important role. And then we all have a responsibility to stand up to these politically motivated actions and speak out.
Thank you. There is a comment here by Jeff, who asked that earlier question about PrEP, to say that a huge barrier is state licensing or care crossing state lines. For example, we can't provide care to youth in Texas. Expansion of this will be hugely helpful.
So we have discussed this extensively, especially in light of the pandemic, but then as we work through and out of the pandemic in terms of telehealth. It isn't simple, because licenses are by the states. There is no federal medical license, as you know. And so your license is by your state. And, you know, some states have reciprocity, but other states don't have reciprocity. The federal government has no authority to directly change that. Now, there could be laws in Congress that could change that. Although with our current makeup of Congress, that's going to be hard. But I don't believe that there'll ever be a national medical license, but there could be laws that require reciprocity in terms of license, so that you could do telehealth across state lines. But the question is, can we do that by regulation change at HHS, or does that require an act of Congress? The current thinking is requires an act of Congress, which requires a Congress that will act.
There's so many questions here.
Yeah.
Thank you for your time and advocacy, Dr. Levine. Can you comment at all on the legality of what you described in the school in Minnesota of disclosing sexuality without consent on the basis of software? Who's making the software? I
don't know who's making the software. We're right here in Silicon Valley, so probably somewhere here. I don't. It would depend upon Minnesota's laws, but that is the insidious nature of the quote unquote "don't say gay" law in Florida, because it specifically said that not only could two schools do that, that they were required to do that they were required to divulge sexual identity and gender and sexual orientation and gender identity if they discovered it to a parent. And so in the Florida, it is outlined. In Minnesota's law, I don't know the legality of that. It depends upon, some of the privacy statutes of their law for youth.
Here's a comment by Steve Adelson. Thank you, Admiral Levine, for your leadership and support of child and youth mental health. We have been grateful for the recognition of youth mental health crisis, but have yet to see large increases in the funding for child and youth mental health services at SAMHSA and throughout the federal agencies, especially in proportion to overall mental health funding. How do we, as expert medical professionals, address the need for more funding for youth mental health services, parity for youth mental health reimbursement, and a larger focus on an expanded youth mental health workforce?
Sure. So we are working on all of that. So there has been a significant increase, not just for youth mental health, but for mental health. It was, I believe, 1.5 billion put out during the pandemic, 1.5 billion for substance use and 1.5 billion. Now this goes to the states for mental health in general as part of COVID funding. So there has been, and that was last year, put out at the beginning of the Biden administration. That money goes to the states, and then it's the states determine how they're going to allocate it. But you're entirely correct. We do need we need new thoughts. We need new policies. We need new funding. I'm very pleased to co-chair the Behavioral Health Coordinating Council for the Secretary with Assistant Secretary Delphin Rittman, who's the Assistant Secretary for SAMHSA. And we have many different subcommittees, one working specifically on youth mental health, one looking at workforce, one looking at the intersection of physical and mental health, trying to embed mental health professionals in primary care and even specialty clinics. So and of course one for overdoses. So we are looking at really trying to have mental health transformation in our country, and then we will be asking Congress in 2023 budget, which would essentially usually be approved by October 1st to fund that. So, but again, a lot of that money from SAMHSA, there are grants that go out to, for instance, academic institutions, but a lot of the funding goes to the states through their block grants, which then go out to clinicians and academic institutions.
There are a couple of questions here about what pediatricians can do to make their offices friendly to LGBTQ plus youth. So what can they do in their offices and in our clinics, such as our own clinic here at Stanford, to make it more friendly?
Sure. I think that there are a number of things that you can do. One thing which is very meaningful to LGBTQI plus people and particularly youth is putting up a pride flag. Putting up, especially the recent one, which has even more colors, et cetera, and putting that up in the waiting area. I mean, it doesn't have to be huge, doesn't have to be the wall, but just maybe even a sticker that really kind of tells kids that you are supportive. It's a little signal that you are supportive. And so I would recommend that. I think that you need to kind of set policies about sexual orientation and gender identity that include, of course, all of your staff, the people at the front desk and your nurses and your medical assistants, et cetera. And so, learn what pronouns your youth prefer. Learn what pronouns your adolescents prefer and use those. Learn what name they prefer and to use that whenever possible. Now, I know it can be challenging because many youth have not had the opportunity to change their gender marker or their name. And so, on their chart, which I know has to be what goes with their insurance, it might be John Smith, but maybe they want to be called Sarah. And so, maybe they don't want their parents. So you have to learn all that. And then, you might say, John Smith, come in, and then they come in and you can, when you go into the room, have your staff and you use the name that they want. So you're going to have to learn, which kids are out, which kids aren't, and to nuance that in your offices. And it starts with the people at the front desk, and it goes all the way through your nurses and your medical assistants, and then all the physicians in the practice. Learn what resources are available for LGBTQI plus youth. Learn what resources are available in your area. Now, in Palo Alto, you're going to have resources. If you're in rural North Dakota, there's going to be a lot less resources, but learn what they are. If they need a support group, where's that? If they need, mental health, you make sure you have a qualified mental health provider. So learn all of those so that it can be facile for you. You don't have to, you don't have to call them back or anything. You can have it right there in your office.
Many of us actually wear this button, which you may see, and it's interesting, talk about advocacy. This project was initiated by a resident rotating through adolescent medicine. And that resident developed these buttons after a 1-month rotation. Another question related to the summer theme: how do you counsel children in your office when they come to see you? How do you ferret out causes of gender dysphoria? Are there simple questions doctors can ask patients to help identify?
Yeah, I mean, there absolutely are. And there's, it's pretty well established now. And I'm sure that the physicians in your gender clinic would be able to sort of maybe do a grand rounds in terms of what questions to ask and how to ask them. Of course, as for all teenagers, confidentiality is critical. And so, the first thing is you have to ask the parents to step out of the room. I learned that's adolescent medicine 101 that I learned in my fellowship in 1987. And even before as a resident, you have to ask the parents to leave the room. And when you're going to talk about sensitive social issues and assure their confidentiality. Of course, if they tell you they're going to actively commit suicide, that's not confidential anymore. Or if they have a gun and they're going to go to school, that's not confidential anymore. But if they say, doctor, I don't know about my sexuality, I might be gay, then you don't go tell their parents. And there's set ways to ask those questions. So you don't walk in the room and say, hi, I'm Dr. Levine. How are you? It's nice to meet you. Are you gay? They probably don't like it that way. You need to kind of work your way into those questions. So, there's a set way to do that. And that is well established in pediatrics and adolescent medicine. And I'm sure that that Neville and your adolescent medicine faculty could kind of go over how to nuance that in a confidential way. I think kids are willing to talk about it much more than they were 10, 20 years ago. And I think that's a good thing. That's not contagion. That's because they understand, that the language is there and they understand themselves. When I was 14, 15 years old in 1971 and 1972, there was no language. And what would you say and who would you tell? But it's better now.
I would agree 100% with that. We do the heads assessment and we educate all of our residents to do that. And it's actually surprising how many young people, even at the age of 12, 13 and younger, actually acknowledge that they either are not sure or they may be trans or they are gender non-binary. So if we ask the questions, they will tell.
I think if you ask the questions, they will tell you. Then you need to know what you're going to do when they tell you. So be careful what you wish for. Because when they tell you, I mean, you can't, you have to react in the right way and then provide support, referrals if necessary. Some will, some won't. And then resources, they might ask for what's a good website. I don't want to disillusion you here in Silicon Valley, but not everything you find on the internet is accurate. And so you want to be able to have maybe some good resources for them.
There is a comment here in the chat from Bonnie Helpman-Felscher from our division about pronouns. And she says, yes, pronouns are critical, but make sure that, and then use the pronoun. I found that asking for preferred pronouns and then not using them is more painful than not asking for pronouns at all.
So I would agree with that. I mean, when you ask, use them. Now, sometimes we make a mistake. None of us are perfect. And sometimes we might inadvertently use the wrong pronoun. And so then to say, oh, I'm sorry, apologize. You don't have to apologize 27 times. That aggravates them. But you can just say, oh, I'm sorry. I know I slipped, but I'll do better. And then really, really, really try hard to do better and get the pronouns right.
Here's another question. Is there evidence that more than one supportive adult impacts youth's suicidal ideation regardless of SOGI? Thank you for the evidence and policy updates.
I don't know the answer to that question. Neville, do you know? I mean, about...
I do not. No.
Yeah, that comes directly from the Trevor Project. And I've read that article and that study. It wouldn't surprise me, but I don't have evidence to that. We'll have to check on to see if there's evidence.
Well, here's one, not a question, but a statement. This presentation was thought-provoking, affirming, and transformative. Thank you for being a strong voice for our community. And that's from Catherine Krause.
Thank you so much. I really appreciate that.
And here, there are more questions coming in. We still have a couple of minutes.
Yeah, great.
Here's a question from Charles Brummer. what role does religious fundamentalism play in anti-LGBTQ attitudes in this country, and how has this been addressed?
Well, I think it does. I think it does. And we certainly do believe in religious freedom in this country as well. I think that it does play a role. But I don't think that, I mean, we have separation of church and state. And so I don't think it should play a role in terms of the laws that and the actions passed by states. I mean, how does that relate to the action in Texas where the governor and the attorney general have asked the Child Protective Services to investigate any parent who is helping find gender affirmation treatment for the young person? So and there have been families that are being investigated for child abuse with all the threats that could entail because they have access gender affirming care for their child. And many of the clinics in Texas at Texas Children's Hospital have closed because of the opinions of the governor and the attorney general and the legislature in Texas. So I don't think that's a religious issue, right? Because we have separation of church and state. So we should be able to provide gender affirming care at expert children's hospitals such as yours, even if other people don't agree with it.
Thank you. So here's a quick question. From where can we get the sticker? I think this was referring to
where you can get. Yeah, I mean, I think you can buy a Pride sticker anywhere. You just go online and look at Pride flag stickers. This is Pride Month, by the way. This is June. This is Pride Month, and so I mean they're available at many stores. I'm sure throughout Palo Alto. I don't know where you get the buttons though, Neville.
The button. Oh, maybe that was the question. The buttons. We can get buttons over here. They do say Stanford Children's Health, but I could get you that if you emailed me directly. I could get you some buttons. There are a couple of comments about the correct and incorrect use of pronouns. Kyla Kent says, and exactly, if a mistake is made, apologize, it goes a long way. And then Dana Weintraub said, a very thoughtful friend once told me to say, thank you for correcting me, rather than sorry, as sorry puts the burden on the person to say something in return.
I like that. I hadn't thought of that. I think that's great. I agree with that completely. It's not their fault that you made pronoun, but I think the other thing that we do sometimes is we feel so badly is we keep apologizing and we say it over and over again. That just aggravates them. I can guarantee you it aggravates them.
Here's another question. How is the United States using its leadership roles to advocate for quality care for LGBTQ+ youth more globally?
Well, that's a very important question. And so there is an LGBTQI+ person at the State Department that is advocating around the world for LGBTQI+ individuals and more affirming laws. We are seeing in other countries very negative laws about LGBTQI+ people. I'll use Hungary and Poland as an example. I'll take it as a point of pride that I have been permanently banned from Russia. I'm on the list, and so I will never go to Russia because I am on their lifetime ban list. I'll take it. Russia, obviously, with all the challenges we have in Russia, but Poland, Hungary, and others have passed some very negative LGBTQI+ laws. So we are working the best we can. There's a specific, she's not an ambassador, but she's a coordinator at the State Department working on this, and we've met with her.
Okay, one other question from Shivani Geha. Thank you for a thought-provoking presentation. The US Census and several national surveillance studies do not directly include LGBTQ+ populations. Are there any efforts in this area? Yes, there are.
So, the previous administration was essentially working to erase us, right? So I don't have to tell you all how important data is, right? How important data is in terms of medical practice, in terms of academics, and data in terms of policies in public health and in medicine. I mean, we always want to use data, have a data-driven public health department. And without data, then it's very hard to help a community that is facing health disparities. And the previous administration made a deliberate attempt to erase SOGI questions from all questionnaires, including the census, so that we would be erased and we wouldn't exist. I can tell you now that we will not be erased. Our community, our broader LGBTQI+ community will not be erased. And the Biden administration is working across HHS and really across the administration to add back appropriately SOGI questions, appropriately asked SOGI questions into all of our data. As you might expect, that's not easy, but we are working to do that.
And I think we have time for one more question, and this is from Lisa Chamberlain. The Pediatric Action Alert coming out later today in honor of Pride Month provides community resources for LGBTQI kids and families, as well as info on a couple of bills in Sacramento supporting these issues. If you don't currently subscribe, send me an email and we will get that to you, get you on the list. Thank you, Lisa. Well, our timing is perfect. And Admiral Levine, I just want to thank you from the bottom of my heart for coming to speak to us at Stanford. Your presentation was thought-provoking and a strong call for advocacy for every one of us, whether it's with our individual patients, whether it's within our practices and our clinics, or whether it's within agencies at state and national level. So thank you very much.
So thank you so much. It was a pleasure to be here. And Neville, I'd like to thank you personally in front of your peers for 30 years of friendship and collegiality.
Thank you.